Hi guys, let's start the remaining part of epilepsy. In this video, we will discuss about the investigations and the management of epilepsy. So let's start with the investigations. In the top, I wrote about the EEG that it confirms the epilepsy. Yes, it does. It is one of the investigation tool that we do the EEG. But which EEG does confirm? Not all time EEG. What does it mean? It means that the EEG which is done during the seizure attack is the one which confirms the epilepsy, while the one which is known as the interictal EEG. Interictal EEG means that EEG which is done in the interictal phase. Interictal phase is the phase which is the time period between the two seizures. The time period when the patient has no more seizures attack, and if you do the EEG in that phase, in that time period, that EEG is not usually useful to find out the true seizures. Okay, so interictal EEG not much helpful for diagnosing the true seizures. Why I'm saying the true seizures? Because they are also the pseudo seizures too, which are actually not the seizures, which are actually the psychological condition which presents as a seizures, psychological conditions. Okay, so why we are calling a pseudo? Because they are not due to any abnormal electrical activity in the brain, while the true seizures are that which are due to abnormal electrical activity in the brain. Okay, so the EEG which shows abnormality during the seizures attack is the one which confirms the epilepsy, which confirms the true seizures. Okay, the interictal EEG is not much useful, it's not much helpful for diagnosing the seizures. Okay, now for the next in the list of investigations, the next is to find out the cause of epilepsy. We have to find out the cause of epilepsy because we have if we treat the cause, the epilepsy would be treated. Simple as that. So first we should have a broad image of the causes, that what causes leads to epilepsy attack. Actually, in the previous video, I told in detail about the causes of epilepsy and what cause we suspect. According to that, we will do that investigation. Say for example, if we're suspecting any structural lesion in the brain, so for example any trauma, any tumor in the brain, or we are suspecting any stroke in the patient, then we do the CT or MRI. Okay, CT or MRI for any structural lesion, and if we're suspecting any metabolic cause or any infective cause, then we do these tests. Okay, say for example the CBC, it will rule out what infection, UC, LFTs. Like why we do these? Why we do these? To find out any renal cause, because in the causes list, I talked about the renal, the chronic and acute renal failure can also lead to seizure fatigue. Okay, CSF, we will investigate the CSF. We can do the investigation about CSF too, to find out any infection, any hemorrhage. Okay, in the cerebrospinal fluid. Okay, with that we actually find out the blood glucose level, the serum calcium, potassium, magnesium, because these also can lead to their low levels. Hypoglycemia, hypercalcemia, hyponatremia can also lead to the seizure attack. Okay, next is the serology, because the infections like SLE, HIV can also lead to the seizure attack. So for the antibodies of this or the lupus, SLE, we can investigate it if you're suspecting the SLE. Clear? Come to this point. Actually, it is elaborating a condition of a patient who is already epileptic and on an anti-epileptic drugs and now present again in the seizures. What to do in that condition? Actually, in this condition, what you do, assess the adequacy of the anti-epileptic drugs, whether they are subtherapeutic, whether they're normal, or whether they are all to the maximum therapeutic range. Okay, if the drugs levels are subtherapeutic, the anti-epileptic drugs are in the subtherapeutic range. What you do? Increase the dose to the therapeutic range. If they are in normal levels, then what you do? Increase till maximum therapeutic range. If the patient is already to the anti-epileptic drugs are already to the maximum therapeutic range, then what you do? You have to switch to another anti-epileptic drugs, because the patient is already, the drug which the patient is taking already on the maximum therapeutic range. You cannot increase further the drug dose, because it will show the toxicity, it will show more and more side effects. So in that condition, you switch to another anti-epileptic drug. How you switch that, what is the mechanism, what steps you will follow, I will tell in detail in the management heading. Okay, so for the management, you should be confirmed that the patient is having a true seizure, not pseudo seizure. Pseudo seizure can be confirmed by EEG. If the interictal EEG is abnormal, it means it is a pseudo seizure. And other features and the history points can also confirm the pseudo seizures. Say for example, if a patient having a history of the tongue biting, having a urinary or fecal incontinence, these are the features which are actually present in the true seizure, not the pseudo seizures. Okay, if the patient's attendants say that the patient during the seizure attack resists their eyes while they try to open it, so this is not a feature of the true seizure. It actually happens in a pseudo seizure. Okay, and if a patient and other point, last but not the least, is that the true seizure can happen during their sleep while the pseudo seizure doesn't. Okay, so these are the points through which we can differentiate between the true and pseudo seizures by history and with the EEG too. Now, when we got confirmed that the seizures are the true, then we have to differentiate that whether they are the partial or generalized. Partial is that one. I described these all in my first video of the epilepsy. Partial is that one. in which one paracerebral hemisphere is involved, and generalized or complex is that in which both hemispheres are involved in abnormal electrical activity. Okay, and these can be differentiated by EG. Why we are differentiating, why we have to be confirmed that which type of epilepsy is patient is suffering from, because according to that we give the drugs are different for the generalized and the partial one. Okay, if we find out that the patient is suffering from the partial epilepsy, partial seizures, we give these drugs. The first line is a carbamazepine, the second line is a sodium valproate or valproic acid. And if the patient is suffering from the generalized seizure, then we should differentiate it with the generalized tonic-clonic, generalized absence, or myoclonic. Okay, now, if the patient is suffering from generalized tonic-clonic, what does it mean? That the whole body is involved, okay? And the body first goes into the tonic phase, like stiffness, and then goes to the clonic phase. As its name indicated, that the tonic comes first, so body will be stiffened first, and then clonic. The body will shift to the clonic stage, in which there will be the jerky movements. For this, the first line is a sodium valproate, and the second line is the lamotrigine. And generalized absence seizures, it is that one which mostly occurs in the childhood, means in the children, and in that condition, what happens that the children goes into the daydreaming stage. Like say for example, and it's for very short duration, for seconds, for 5 to 10 seconds, and but for multiple times, like 20 to 30 times these seizure attacks happen in that patient. Okay, say for example, a child is sitting in the classroom, and what happens that he's sitting in the classroom and writing his work. Suddenly he just stop everything, he just like become a statue. Okay, like in a condition that he's not in this world. So it's actually the absence seizure attack at that time. For this, the first line is that it comes to mind, but the second line is a sodium valproate. For the myoclonic is that one which there is a single jerk episode. For this, the first line sodium valproate, second line is a clonazepam. I underline the word A and E just to make a link between these two, to remember in an easy way. A, E, I, O, U, these are the vowels. A, E are just near to each other, so learn in that way. Absence seizure, first line, drug starts from the E. While for the myoclonic, the second line is a clonazepam, both having the word clone. So learn in that way. Okay. Now, next is how we start the drug, and if the drug is not working, how we start the second line drug, and what to do with the first line drug. Okay, I'm going to tell you about this stuff. You say, for example, the patient is suffering from the partial seizures. You give the drug first line carbamazepine, but you should start the drug at the low dose, and gradually increase the dose till the seizures attack vanish. And that dose should be in the therapeutic range. It should not reach to the toxic concentration. Okay, if the patient partial seizure, you give the drug carbamazepine, you increasing the dose gradually, and under the and you reach to a dose where the seizures attack get vanished. You then counsel the patient that you have to taking that drug dose lifelong. Lifelong means not for few years, because I'm going to tell you about how to withdraw the drug. So you have to maintain the patient at that drug dose at which the seizures attack got vanished. Okay. Next case, I'm just making a scenario like one patient, you gave the first line drug, and the seizure attack got vanished. Now, if the patient, if the seizure attack do not vanish, they are still there, and you are increasing dose, and you increase the dose to the toxic concentration. At that, you won't increase the dose furthermore, because if you increase furthermore, what will happen? The side effects will exaggerate. The side effects are already somewhat will be present even at the therapeutic range, but if you increase the dose till the toxic concentration, the side effects would exaggerate. Okay, so in this condition, if the seizure attacks are not getting control, and the drug concentration you increased to the like more than therapeutic range, in that condition, what you will do, you will start the second line drug. Okay, how you will start the second line drug? From the low concentration, gradually you increase the increase the concentration with time. What you will do with the first line drug? The question is that you won't stop the first line drug immediately. Keep this in your mind. You have to decrease the dose, the first line, slowly and gradually. When you will do that? When the second line drug reach to the mid therapeutic range, or when the second line drug control the seizure attack. At that time, then you will decrease the first line drug gradually, slowly. Okay, same phenomena for all the first line, second line drugs, whether for partial seizure or whether for the generalized seizure.